Peter?
Yo.
Welcome visitors, please. Welcome visitors. Yeah. There you go, celebrity couple.
Now, I'm here today to talk about sickle cell disease and to represent SCAGO. And SCAGO stands for the Sickle Cell Awareness Group of Ontario.
So for diabetes, we have two types. There is type 1, which is also known the juvenile diabetes. It is also called the insulin dependent because when you get type 1, that means you get that diabetes when you're a child.
So when you look at diabetes, 25% of people with diabetes are going to have depression, and people with cardiovascular with heart diseases.
Hi, Ricky Henry Live. Ricky Henry Live. Woohoo! Shout out to Ricky Henry Live.
The future of healthcare is being shaped in Toronto, and you don't want to miss it. On June 27th and 28th, 2025, healthcare professionals from around the globe will converge at the 237 Sackville Banquet Hall in Toronto, Canada. Hosted by the New Afro-Canadian Foundation, this conference is your gateway to exploring the future of healthcare innovation and solutions for sustainable lifestyles. From tackling HIV, AIDS, stigma, to groundbreaking cancer research and improving social care assistance, we're covering it all. Connect with leading experts, discover cutting-edge technologies, and collaborate on impactful solutions. International delegates, your investment is $350. For international exhibitors, it's $550. Local exhibitors, you're in for just $250 Canadian. And guess what? Local delegates get in for free. Mark your calendar, register now at www.newafrocanadian.foundation or email us at info@newafrocanadianfoundation.org. Eventbrite at New Afro-Canadian Foundation, e-transfer Catherine Kabite at yahoo.com. For any inquiries, reach us at our +1 647 271 6223 or +44 777 013 6491. See you in Toronto, where the future of healthcare begins. Well, be part of the change.
When you are dealing with chronic conditions, I'm telling you, human being cannot be having chronic condition. The treatment of chronic illnesses. For policymakers, we need to support policies integrating mental health into chronic care surrounding mental health. That is why I kept on emphasizing that these are called predisposing factors and they're not the causes. Sometimes we say the cause, the real cause is unknown. But research find that.
Which includes the sickle cell disease treatment demonstration program. It is about the sickle cell disease newborn screening and program.
Recommended by the medical people.
How are you doing?
So, in conclusion,
I'm seeing Canadian Samaritans.
I want you to know that depression and chronic conditions
What's it all
are
about?
deeply interconnected.
We are supporting women in a number of countries in Africa so that they
There is no way that someone
develop
can
autonomy,
have
they can start their own
chronic
businesses. So
conditions
we
and be depressed.
raise money so that they can be
If
trained up
it is something
in
that is
various
for 1 year, 2
skills,
years, and goes
whether it be
away,
farming or
they can
tailoring
start.
or, there's lots of different
I also
examples.
want you to know that early mental health
Poultry farming, all kinds of
can
different
improve
things. And then what happens is that we have seed money so that they can start up their businesses, and then they're able to support themselves, their families, and often their whole communities. So our motto is we build on the assets of the African woman.
Bane mbalamusiza mwenna amanya gange nza Pofiate barra mwenna mumanyi mama Matini abasinga bampita abamu bampita mukadde ndi wano mbayita mujje mumpagire ebintu byonna mbirina
Ngaki
sinna kyentalina nga bw'olaba bw'ogenda e Kampala n'ogenda ku African Village oba ku Buganda Road buli kibeerawo kyonna kirina akasimu kange osobola okukankubira
namba eriki
647-770-2686 anti olw'e Kampala lwadde tukyandimu enamba njogera za Kampala naye nga eri 647-770-2686 kubira akasimu nna buli kimu n'amasaati amalungi ag'abasajja nina ebiteeteeyi ebirungi eby'abakyala nina necklaces nina endeku enkofiira nina buli kimu nga ebintu ebiba ku Buganda Road nina ebibajje giraffe elephant lions buli kimu
ebintu bino bireeta otya okuva e Uganda
bireeta ku nyonyi bitika ku nyonyi era abamu bagamba biseera naye nga si biseera kuba mbireeta mu kilos
toseera
siseera
katugezeseemuko kati akantu nga kano kali mu sente mmeka
akantu kano katunda $2 zokka
2
ez'e Canada
omuntu ayinza kakozesa ki
kano akantu nga bwe mumanyi waffe abantu abasinga banyweramu omwenge oba n'akateekamu for decoration
gye bayita endeku
naye kaakati abantu bano abasinga wano babweyambisa nga bwe mumanyi mu paaka abantu bagenze kusanyukamu ne bakkirizaayo omwenge kati oba nakengeko okayiwa muno n'osoloweza mpolampola asikaali n'obwakuyitako tamanya nti mulimu kali weyalowooza nti mulimu amazzi oba biki n'obulaabulizawo n'otwaliriza embeera kifo ekyokubeera wali n'onywa ebisooda amazzi kati oteeka muno n'obuzaabuza mpolampola ovamu ng'oyongeramu
ate nga okumakalica yaffe
buno bulabika bulungi bane bujje mu mpagere sabatentalina abayesu bali bano
nawe ebintu ebyenjawulo so omukatuliki asobola okujja n'agula Yesu
n'atali mukatuliki yona biriiva asobola okumanya n'omulokole omuntu asobola okujja n'agula nawano ebintu byonna buntu buno bunyumira nnyo abaami abateeseeko especially buno bw'abaami bateeka ku mukolo ensi yaffe n'oba ng'ogitunze wano ogiwadde buli nsi eri wano by the way buli nsi yonna gy'oyagala enjawulo
Canada njiraba America Nigeria Jamaica zonna kweziri
alina bano abanoonya change sente ne zibakwako n'obuntu obulungi okutereka change teeka muno buchenji bwo n'ojja muno obala n'obaweereza n'osasula buli kyoyagadde okusasula change ziggwa oteeka mu mpala ogenda kujjamu nga tokyaziraba nina wano amasaati amalungi
olinawo n'amasaati
nga bwe mugalaba different colors agaba nina wano nice jackets nga zino abaami sobola okuzamba ne munyuma nina wano byemizanyo byaffe oyambala
eringa mu sente mmeka $5
gokka
$5 zokka
$5 bino biteteeyi buli kimu kiri wano n'ensawo zaffe nina ati ono aba mulungi oteeka mu nyumba nga nokaaba kadizayininga bwekiti nga kikyokola katimba ku kisenge n'okwasa wano gamu oba kapini na wano ekabanga wekali mulungi ati wuuno nanyumira ku bisenge different colors different design tulina wano ebintu ebirungi eby'abaana okuzanyisa doleze waffe ziraba
doleze waffe zennyini
dole talambadde gomasukulonda nane bebikuba kano
kati omwana naye oba omuzaalidde wano asobola okufuna
amanya nti zino dole ewaffe eyawaka n'akyusa mu zino ezibeera wano namanya nti wano omukyala omunayuganda yambala bwati ng'alina n'omwana n'amanya nti ewaffe bavuga obugaali nebateekako n'amatooke n'avuga oba n'atwalako omuntu kati ono aweese mukyala we balina n'omwana kwegamba abaana bazaaliddwa wano n'amanya nti eno bayisiko baweekako omuntu baba bamanyidde bubayisiko buno bwa wano tetoluga oweeka naye kakabirako kasimu
enamba nsaba ogiddemu
647-770-2686
mukyalaani
bampita mukyala
apofia
nsula kipling and
Finch.
omuntu ajja tukwatagana netulaba n'okebera mukyetaga n'okebera ebyokukiipinga okujjako kati nga bino ebibumbe bwoba obirabye kyo nsobola okukiipingira naye bino ebirala ebisigadde kyetaaga n'oba nga wejjudde n'okola kyoyisi n'oda kale mbakuumye nno mbaagala nnyo
tweyanziza nnyo tweyanzeege
that we need to create these long-term relationships that promote and advance the efforts that we're trying to do. We want to make sure we're looking at building an advocacy team. Who should make up those teams? What should the meeting schedules be? Who are the people that are directly affected by the choices that we're making, by the advocacy message that we're trying to deliver? Who are the friends and family? Looking at those healthcare practitioners. Providing understanding what our goals as well as our limitations may be. We want to make sure that we're taking notes and learning from the communities that we're trying to serve. And we always want to take the initiative to continue the discussion and to stay in touch. So we want to make sure as we're doing this that we're also including supporting materials that can help us to clearly
I do that. As we sit now, our body is doing a lot of this to maintain us. But one day, if your body breaks down and cannot regulate something in your body, it becomes the other side of the world. And that is when your weakness comes, and then we say, you are presenting with such and such condition. So for diabetes, this is what happened. Over the time, if your sugar level begin to play around like that, you start developing problem with your heart, blood vessels, you get problem with high, which we call the diabetic blindness, your kidneys, and then the nerves. We have seen people, they have problem with the food, and probably the toe or something has been cut off because the nerve ending is not receiving anything anymore. So that is how it advances. So for diabetes, we have two types. There is type 1, which is also known the juvenile diabetes. It is also called the insulin dependent because when you get type 1, that means you get that diabetes when you are a child. That one runs in the family. It is a chronic condition because you're going to live with it forever. So in this case, the pancreas produces little or no insulin by itself. That means the medical team is going to work out for you to have artificial insulin to run your body. Type 2 is the most common. This is what we get due to our lifestyle, and I say these are predisposing factors, not the causes. We say it is associated to. So usually it affects the adult and occur when the body becomes resistant to insulin or doesn't make enough insulin. So that is how we end up with diabetes. Then we have obesity. Obesity has become very common, and it is a type of malnutrition that is characterized by abnormal growth of adipose tissues. The fats are deposited in some part of your body and making your body to abnormally swell. So it occurs due to increased size and the number of the fat cells in your body. How do we know? Your body mass index. There is a way we calculate the body mass index, and we are supposed to know that a person of this height is supposed to have this weight. If you are at this height and your weight is this, then you are going beyond the normal. That is what we call the body mass index. And if we calculate and we find it more than 30 for male or more than 28.6 in female, then we say this person is obese. What are the predisposing factors? Age, increases with age. As the age increases, especially for children, the infants that gain overweight after birth, at the beginning you'll be happy because you are carrying a very big child, and then everyone, when they see you, you're excited. But that child, if not controlled, is a potential candidate of obesity in the future. Then sex is another predisposing factor, common with female because of menopause. They tend to gain more weight during menopause. Then we have sedentary lifestyle, where everyone just feel like, if I can only be in my world where I just sit and I sleep and I only go in my car and drive around and come back and see, it's a very nice life. So you are not breaking or burning the calories that you are taking. Besides, you're being inactive. Remember, you're eating breakfast, lunch, supper, and something in between, and a lot of snacks, and you are not breaking them down. So that all will lead you to obesity. And then we have the genetic factors which runs in the family, because your uncle, your auntie, your grandfather was that. And that one, you keep it in your mind that you're likely to be a candidate of obesity. Then diet, where you take extra calories which are not necessary for your body, but you keep on pumping it, and then because you don't want the stomach to remain empty. Then we have psychosocial factors due to the influence of eating habits, restraint. The previous speaker gave testimony of emotional eating, where someone is stressed and then you just resort to food. When I started in my first year of PhD, my best friend was doing that. Every time we are stressed with book, she would tell us, let's go and entertain ourselves with food. So myself personally, we did that a lot. So you entertain yourself with food, and then you end up into obesity. Then we have the endocrine hormone, where people who are obese have the hormonal influence that encourages accumulation of fat. So the fat keeps on accumulating. How do we prevent? That means we should work on our, if you take me to check my blood pressure, check my diabetes, check my all other chronic condition, and check my mental status as well. Giving preventive, emphasizing on preventive strategies. Curative, palliative is the care I give to someone who is in terminal state. Somehow it helps the family from getting depression and so on. And then all this care has to be context appropriate. How can we deliver this? Through having the policy and legislative and regulatory measures that support. So, How does chronic disease present? They are not transmitted. I already told you they are not transmitted from one person to the other. They relate to each other so much. Sometimes it's very confusing to know if you have this or you have that or you have both until you go to hospital and you are examined and assessed and the investigation will tell you what you have. So not only relate to each other, they share risk factors. We are going to see a wave of if you smoke, what can you get? You can find out only smoking alone can give you that. If you survive that, can give you that. If you survive that, can give you another one. So they share risk factors, they coexist. That is why if hypertension comes, you know that diabetes is on the way. Diabetes comes, you know that your kidney is going to get problem. And then eventually they will say you died due to multi-organ failures because all the organs are now responding to what their friend is calling them for. They have a long-term latency period. They don't just come today and tomorrow you have hypertension. No. You don't just smoke today and tomorrow you have problem. No. You've been smoking, you've been abusing drugs, you've been doing all this and then enjoying, and then building slowly, and find yourself with chronic condition. They are long-lasting. I said when they come, they don't go away easily. And then they have high mortality and morbidity. If you are not dying, then you are not living peaceful, because every time you have to think about the drug, you have to think about visiting the doctor, you have to think about, you now begin to force yourself into diet that you are not used to. You are not used to that diet. The end of my presentation today.
Wow. Thank you so much, Dr. Nancy. She has really taken us through a lot. We are going to have a discussion, but I wanted to have the presenters have their presentation, and then we'll get into the discussion after lunch. If that is okay with you, just give her more applause as she takes us. Thank you so much. When she was talking about, diabetes, there is a lot of sugars here. You eat this, you eat that, and it's all about exposing us to that kind of chronic diseases center. The tobacco wave scared me a lot. I don't know whether we have some smokers here. If you're there and you remember that wave, you need to watch your smoking habits. You're gonna allow me to invite, I'll give you a brief synopsis. Dr. Edward Donwell is the education manager at the Sickle Cell Awareness Group of Ontario and the registry of mentorship manager at Gansi prior to joining, now this one is brief, the Sickle Cell Alliance Group of Ontario. And Dr. Ivy worked with the Mental and Child Health Bureau of the Health Resources and Services Administration in the United States as the program director of the hemoglobinopathies. That one. The doctor's language. By the end of this conference, I'll have a PhD. Which includes the sickle cell. Doctor, could you please come briefly and give us your presentation?
Yes, and I know I had brief discussion, so I'm going to try to make this quick. I'd like to thank you all, though, for inviting me out here to talk to you today about sickle cell disease. I am, as he said, a doctor, but I'm also a person living with sickle cell disease, so I know firsthand how severe the disease can be. So there's definitely things we need to understand as we hope to treat individuals with sickle cell disease. But there's good news as well. So I know we acknowledge the land. We are grateful for the opportunity to gather on this land, and we thank the generations of indigenous people who have taken care of this land long before our nation came along. We acknowledge the traditional territories of the Ojibwe and Ashabi people, and the Mississaugas of the New Credit, whose territory is covered by Upper Canada treaties. We are grateful to have the opportunity to live and work freely on these lands. I am reminded of our responsibility to continue to educate ourselves about the colonial history of this country, and we also need to continuously do the work that needs to be done to undo harm of settler colonism and to ensure that all people, particularly indigenous people, have the same privileges, opportunities, and freedoms that are rightfully theirs. So I encourage everyone at this session to actively seek and take action. Now, I'm here today to talk about sickle cell disease and to represent SCAGO. And SCAGO stands for the Sickle Cell Awareness Group of Ontario. SCAGO was started in 2005 as the Seed of Life philanthropic organization in memory of the brave Sunday Aflodi. So SCAGO is a leading charitable patient organization providing evidence-based support to families with children, adolescents, and adults with sickle cell disease across the 4 regions of the province. It supports and engages research, health promotion, patient, and care among the individuals in the community. Now, what does SCAGO stand for? What is our mission? Our goal is to really optimize the lives of individuals that are living with sickle cell disease. This is a broader vision of every Ontarian with sickle cell disease should have equal and equitable access to comprehensive case, something that individuals want to hear and want to act on. So what are the facts of our arguments? What are the lessons we're trying to get across to other individuals in our community? How well is our case presented? Are we presenting a clear message? Is it articulated properly? And is it being delivered to that target audience so that they can take action? And then is it a timely case that we're making? Are we delivering it at the right time to make that maximum impact? Now, as we look at sickle cell disease, and that's what I'm here to talk to you about today, one of the things we want to consider is the distribution of sickle cell disease. And we can clearly see that most individuals with sickle cell disease, we do have some impact in Canada and the United States, but the majority of individuals with sickle cell disease comes from sub-Saharan Africa as well as India. And as we look at recent immigration patterns, looking at where individuals are coming to Canada from, we can see that a lot of individuals are immigrating to Canada from those sub-Saharan African regions where sickle cell is more prominent. So we have to figure out what are our best outreach strategies to reach those new immigrants to Canada that may be impacted and affected by sickle cell disease so that we can get them into care. We also have to consider those cultural competency issues and those language barriers that may exist that may play a role in our ability to reach the sickle cell community. As we look at Ontario specifically, we can look at a study that was done by Ontario Health between 2007 and 2017. And it identified that within Ontario, there were 3,418 individuals living with sickle cell disease. The slight majority of individuals were female, so there were 55.9% that were female, and the median age was 24 years. Now, during that 10-year span, 229 individuals died with sickle cell disease, and the average life expectancy for individuals with sickle cell disease was 55 years. So the great news is that individuals are living much longer with sickle cell disease. So as it was mentioned by previous speakers, we can't just focus on the sickle cell disease. We have to think about mental health. We have to think about education. We have to think about jobs. And what are those other opportunities that we can present to the sickle cell community to help them be effective members of society? As we look at sickle cell disease, we know that it can affect every organ of the body. It has impact on neurocognitive abilities. It can cause strokes in individuals. There can be retinopathy that was mentioned earlier. With diabetes, we have to consider this can play a role in sickle cell disease. There's other complications, but we know that also pain is a hallmark of sickle cell disease as well. But as we help individuals with sickle cell disease to address that pain, we do often also have to consider that sickle cell disease affects many parts of the body, and every organ of the body can be affected by sickle cell disease. Now, as I mentioned earlier, the great news is that the life expectancy of individuals living with sickle cell disease has greatly increased. We've gone from individuals that would die at 5 years of age, they didn't really have that expectation that they would live long, to now, as I presented earlier, individuals in Ontario living to age 55 from sickle cell disease. And this is due to some of those advancements we had made in addressing sickle cell disease. So it includes identifying that penicillin prophylaxis can be an important therapy, and then also hydroxyurea. That is a therapy that we now have for sickle cell disease. But in addition to that, and within the last 5 years, there have been significant advances in improving the advocacy message that we're trying to deliver. Who are the friends and family, looking at those healthcare practitioners, how do we create partnerships with them, third-party experts that may exist in our community, as well as trusted colleagues and supervisors. So understanding effective advocacy interactions means staying focused on the message. What are we trying to do? Being polite and respectful, providing practical and achievable recommendations for action. So we can't ask for the moon. We have to look at the community we live in, and what are those actionable items that we can promote? It also means giving precise examples and documentations of those experiences. We want to do our homework before we go to deliver those messages, understanding what our goals as well as our limitations may be. We want to make sure that we're taking notes and learning from the communities that we're trying to serve, and we always want to take the initiative to continue the discussion and to stay in touch. So we want to make sure as we're doing this that we're also including supporting materials that can help us to clearly communicate our ask, be concise and practical, ensure that they're easily accessible, as well as providing references and contact. So we want to make sure that we have those materials to explain to those policymakers as well as those community members what it is that we're asking about and the actions that they can take. We want to make sure that we're building those relationships with key political advisors and elected officials, meet them to build those relationships. So going to our local leaders, our local political leaders, to make sure that our lessons are heard. We want to make sure that individuals that are in the parliament are aware of our ask so that they can then take actions towards our goal. And then we have to keep in mind that we can attract more bees with honey than we do with vinegar. This means establishing common ground, sharing our personal experiences and goals, and making sure that we're really delivering our message home. We want to be able to frame the conversation based on the facts that we want to offer in improving care. We want to look for those opportunities for advocacy that are much greater than us. So thank you so much for having me here.
Samaritans Africa, or for Africa. She is present and she has something small to say.
Organization, all of the money that we collect, we send and to support cohorts of women so that they can be trained in various skill sets and they are able to use those skills in order to build their own businesses. So, for example, we have a cohort who has gone into farming, groundnut farming. They've done tailoring. They've done poultry farming, piggeries, salons, all sorts of different things. Historically, we have been in countries such as Uganda. We've been in Kenya. We've been in Burkina Faso, South Sudan, and the Democratic Republic of Congo, and Nigeria. And I know I'm missing others. Right now we have 2 projects that we are working on in Nigeria. And my booth over there, we have some more information. If you would like to be a volunteer, we welcome your support. I'm very, very grateful for this invitation and met wonderful people, and I love what I'm hearing. Our founder, Father Stan Chu Ilo, is someone who is very much interested and has done a lot of work in global health. And so I was just texting him and saying I'm here, and it would be so good if he was here. He teaches at DePaul University in Chicago. But I'm happy for these meeting all of you new friends. And if you would like some more information, I'm back there and looking forward to having more conversations with you all. Thank you so much for your time.
Thank you so much. I was just waiting to hear name Susan in the conference, because the name Susan is so special. You'll never find a Susan who is not amazing.
Please make sure you don't close at someone else. DJ, play us the song.
Now we are going to serve lunch, so that prayer. Who is going to pray for us? Myself? Okay, Lord, we thank you for this day, and we thank you for the food prepared for us. Bless this food so that we can benefit from it in a health and productive way. We ask you through Christ our Lord. Amen.
Chicken. And this? Chicken. Have you tasted it? Have you seen the camera?
Chicken?
Yeah. One more?
No. I know. Yeah, I'll take one. Great. Thank you.
Chef Alan Peter.
Yo.
Malaba. Mugitambuza bulungi mwanyumye mu uniform awo banani. All looking nice. Yeah.
Ready?
What happened to your education system? Now what? Education system like in country. I'll tell you.
since I took the USMLE.
Oh, okay.
That was back in 2000.
Wow, that's way back.
24 years ago.
I was in the secondary by then.
Buddayo ku ddabo lya gundi greens zokka.
They're nice, eh? I think they're mayonnaise, eh?
Okay. Try? No.
What's the sugar? Leave the sugar. I said, oh my God.
I live without sugar.
I live without sugar. I can't live without sugar. And that's where the problem is going to hit you hard. So these are the challenges that mental is going to come from when it comes to chronic diseases. If you have cancer, you say now 2 years have died. Now.
Take your seat. The next song needs you seated. Thank you for the groove. You can open your mouth and say, Lord, I'm believing that you're going to lift me up. Hey, lift us up, Jesus. Lift us up, Jesus. Where the eagles fly on a mountain high. Where's the sea where we belong? Far from the ngamba Yesu.
Anti Yesu olowooza atakuli wala ali wano naawe. Jesus is like me. And Jesus was a man. And you know she's singing and searching.
Are you sure?
Mr. Livingstone Sechanzi is a managing director, or an MD, is an experienced medical director with over 10 years experience in healthcare industry in Uganda, an experienced clinician, health services leader, and a public health specialist and who is passionate about mental and child health. Allow me, ladies and gentlemen, to welcome Dr. Livingstone Sechanzi.
This conference, for the opportunity to be here to present to you, and we call it a day of managing chronic diseases, drug abuse, mental health, all in one. So, as you have heard, those are my names. Dr. Livingstone is my name. I come from Uganda. I've been here for 10 months. I come from the Pearl of Africa. So those who are from the Pearl, don't feel offended. And this is my first winter. I don't know how it's going to be. Hope I will enjoy. When they say the white Christmas, I want to go to church, but the white Christmas is not appearing, you know? Yeah. And in Uganda, when it rains, so it has rained, now there is mud, but here there is snow, you know? So thank everyone for coming. When you look at the program, I'm doing a presentation discussion. So meaning we've got to do it together. Thank you so much to the first presenters. Actually, Dr. Nancy did almost everything and completed all the work we are supposed to do. But nevertheless, we shall be able to wrap it up. The one of mental health, thank you so much. When we go, the MC was saying there and here. When you are there and you speak about mental health, they will see a madman walking on the road. And we have a big challenge with that. Because when you speak about mental health, we are speaking about psychiatry. And one of the challenges we have, if you go to my home country and say, I'm looking for a therapist, I will pray for you. I'm telling you. We have a health system. Go to a hospital and say, I want to see a therapist. So what are you talking about? Are you from here? Please define more. Because when you say mental health, you are meaning a psychiatrist. So they are totally different, and that's why we've got to understand the things that when we come here, when they say, thank you, oh no worries. Okay, so currently I work with the Access Alliance, Mount Kato Health Services and Community Services, and as well I'm a board member of the Newcomers Zone in Toronto. It's a charitable organization that helps immigrants to settle in the country, so I'm one of the board members. And hey, there we go. So as Nancy talked about all the issues, the statistics, the burden, you know, you may not know how big this problem is. And it's because we have not put it in the context as a burden. It's a very big burden. And when I look around, there are few born here Canadians. Many of us have come here either young or at this age. I want to tell you that being in Canada or being a Canadian is a risk factor for diabetes. It may sound ridiculous, but being in Canada is a risk factor for you getting diabetes. If you look at the statistics of diabetes, I think maybe by 2050, 50% of Canadians will be having diabetes. Half of the population of this country will be having diabetes. Ideally, it is called now an epidemic. Those who are like me in medical, an epidemic, it's not like something that comes slowly, like it just and it's there. When we had the COVID, when it was in one country, it can be an epidemic. When it crosses the borders to other countries, it becomes a pandemic worldwide. So in Canada, when we talk about an epidemic of Ebola, of Marburg back in Africa, of measles, we have an epidemic of diabetes. And what is the big question we have here? It is shocking that insulin, the medicine that treats diabetes, was discovered in Canada 102 years ago. What does that mean to us? That they knew the diabetes way back. But why is it an epidemic now in Canada? That's the question we're asking ourselves. Why is it now an epidemic? What is the big problem? Yet it was known 102 years ago, they discovered the medicine to treat it, and now a big problem. We shall reach there. But when Nancy was telling us, we saw the risk factors. Some of them are very modifiable, others are non-modifiable. By modifiable, I mean you can change them. Non-modification, you can't change them. So chronic diseases are preventable. But also how they are killing many of us. When you look at the statistics, they are killing many of us, yet they are preventable. So the major challenge we're going to find in these conditions is most of our governments are investing in the treatment. They are not investing in the prevention. That's the major problem. That's why we have reached here. We are here. And I want to give you an analogy. If you know a river, if you know a stream, there's the way stream moves. There's a down end stream and an up end stream. Now, the upper end stream is where the water flows coming downwards. So the challenge we have is we go downstream to wait to manage whatever comes from the upstream. And we never want to go the upstream to manage it from there. What do I mean? If you have a river, they tell you, in that river, in that stream, children fall in that stream. And we say that everybody is down at the end of downstream. And for you to say, I will train the people to remove the dead bodies at the downstream. Are you dealing with the problem? And that's what exactly we are doing. We are waiting at our downstream to remove the dead bodies from the river instead of going and putting a fence at the upper stream that children don't fall in the river. That is the prevention. We are waiting down. Another one is, many of us drive, we have driven about a car. They tell you, please, you need to service your car. After these kilometers, service the car. After this mileage, service the car. But what will we do? We wait for the breakdown and go to the garage. So our health systems, not only where we come from, even here, have been made like a garage. They wait for the breakdown. We don't do the servicing. Okay? So these are the conditions I've looked at them. The cardiovascular, the heart conditions. Especially, we are talking about metabolic diseases, cancer, chronic diseases, and neurological disorders. These are the categories that my colleague Susan was talking about. And the musculoskeletal, your muscles, your bones, that's musculoskeletal. And actually, some of these things come from the work we do. Especially some of them are from the work we do. Have our work been modified to suit us, or we bend to suit our work? Where the health and the safety guidelines being implemented. So if you're going to be carrying heavy things, using your hands and arching your back, you're going to have a chronic back pain. So you're going to modify the work that you do heavy things but not arching your back. So some of these are the risk factors that we get along the way. Mental health is a big, big problem, as we have seen. And we have digestive issues. People come from Uganda or heard about ulcers, ulcers becomes ulcers. And I think that some of these chronic conditions don't go away. That's the other thing. And that's why we should invest in prevention, because they don't go away. Unlike with fear malaria, which we treat in 5 days and you are okay and everything is normal, if you get diabetes, it's not going to leave your blood. If hypertension comes, it's not going to go away. If you have a chronic kidney disease, you will go into dialysis. If you don't have a kidney transplant, you are gone. Okay? So it's such a big problem that we've got to pay attention to it, but otherwise we don't pay attention to it. Because we think, when COVID comes out to kill my children, yes, but COVID is no longer killing people. We are dying of hypertension. We are dying of diabetes, kidney chronic disease, respiratory conditions, smoking. Smoking, winter has come, smoking is one of the major risk factors in almost all other conditions. Beat cancers, beat digestive conditions, smoking. We have autoimmune diseases. Autoimmune means that your body fights itself. Your body, the defense mechanism, sees yourselves as enemies and begins fighting yourself. If you have like rheumatoid arthritis, it might be autoimmune. Okay? So we have endocrine disorders, hypothyroidism. Many of you know goiter. You know goiter, that's hypothyroidism. There are also chronic conditions, but at times we want to pay attention to them. We have skin diseases, and here we have a lot of allergies. So statistics, we saw them. These are from the American, and she was presented, I think, from the Canadian. So, the risk factors. Some of them are very modifiable, others not modifiable. So, the behavior ones, dietary habits. What do you drink? What do you eat? What do you drink? What do you eat? When you look at our televisions, which foods are being advertised? So, what does it tell us? Are they healthy foods? Now you are seeing where we are going. That we are advertising the disease itself. And we are saying we are in an epidemic of diabetes. And that's where we are. You will not see somebody saying, please, vegetables are very nice. No, burgers, very nice, and McDonald's and everything. What are you eating? You are eating yourself to the grave. Thank you. Maybe because you're in the healthcare industry. Yeah. So those are the eating habits. Poor diet habits, one of the major risk factors, modifiable. You can change it. Physical inactivity. Or shower. How many hours do you walk in a week? In a week, how many hours do you walk?
I walk because I have to.
You see? So, I always tell people, of course, the MC was saying that you can't have it all. There is the good side and the bad side wherever you're going to be. When I was growing up, I remember I came from one of the poorest families in my country. And when we were young, we thought we were eating poorly because we were poor. When I went to the first college doing my diploma in clinical medicine, I knew we were eating very healthy. Why? We could really fry things at home. Boil beans, boil your food. Everything was boiled. You have all the greens, you have natural food from the garden, boil. The nuts, all the types of vegetables, all types of food, and say, oh, we are eating poorly. Now I know we are eating healthy. Even the rice was boiled, it was on fly. Even the meat was boiled, the chicken was boiled, everything was boiled. Nothing else was added to that. Now we say, oh, we are eating poorly because we are poor. But we are eating very healthy. Now that's a challenge that when you are in America or developed countries, when you are poor, you are at risk of developing diseases. When you are back in Africa, those who get the money and become rich, they eat poorly. Thinking they are enjoying their money. They are eating poorly. And that's why the natural diseases come when the countries begin to develop. When you move from low income to middle income to developed, the burden of NCDs increase. We have been dying of communicable diseases back the other side because social determinants of health. We are not vaccinating, we are not eating well, our population is very poor, we are dying of communicable. Now, when we control this, the generation is vaccinated, we are not dying of measles. We can't die of tetanus. No, we can control this. Now, we get a little smaller money, we eat well, we think we are eating well, we eat poor. What happens? Hypertension, diabetes, cancers. So we want to take something home from today, that it begins with me, it begins with you. Tobacco usage, alcohol consumption, excessive alcohol consumption, major risk factors for developing these conditions. I won't go into the science, but major risk factors. Actually, when you read about cancers, risk factors, you find smoking alcohol, smoking alcohol, smoking alcohol, smoking alcohol, cancers. And by the way, when you are here, it is very surprising. You know, when you have just come, you don't have a big community to know about. But I have a church where I go to. And my wife was saying that people are dying every day in church. And I was asking her, how old are they? And what are they suffering from? Cancer. Cancers. So smoking, alcohol use, one of the major factors. So we have the biological ones that we cannot control. And now, why North America or becoming such, having an epidemic of this disease is factor which is aging. We are having an aging population. So when we grow, our bodies change. Many things change about us. And we attract. We become the flowers attracting the bees of the non-communicable or chronic diseases. Unlike when we're young. So the more I grow, the more I get at risk of developing diabetes, hypertensive conditions, kidney issues, cancers, the more you grow. So as you grow, please cut down the smoking, cut down the alcohol. Because you are now compounding the problem, making it now easier to get you. Okay. So when you look at the environmental factors, by the way, I think like down where we come from in Africa and other developing countries, we're going to have cancers we don't know about. I always go see people working in salons, and I see them handling these chemicals with hands, working on people's hair, doing everything, and I ask them, don't you fear handling things with your bare hands? And they're not bothered. But give it 20, 25, and 30 years. These people will have skin cancers. The environmental factors. We have people on roads. You move on roads, people are boiling tar and all that, and they're not having anything to protect them. They're not having any masks. They are inhaling these gases. People who work in mines, environmental factors. They are preventable. But what have we done about them? We leave them to go like that. And at the end of it all, chronic diseases. We have the exposure to the hazards, then we have underlying drivers. So these are the factors that we have the underlying drivers. What are these? Social determinants of health. Socioeconomic factors, poverty, you can't access health, you can't eat well. It's a driver. You can't access health services, and not only here, not only back where you come from, even here. So if I ask, how many of us in the last 6 months have had a test for diabetes? You see? 1, 2, 3, 4. When was the last time you had your blood pressure measured? I will not speak because it's not measured. So, accessing the health services. These are simple things. Simple. If you are above 25 years and you identify as a female, how many times have you had a test for the cancer of the cervix?
government for any woman who does the testing. There's a microphone here. For the Canadian government, they are very specific and particular when it comes to women's health. So if you do test and you are new into the country and you go into their system, they even send a reminder when a year ends because you're supposed to do it at least once in a year. That's an advantage that we have when it comes to cervical testing and pap smear. Thank you.
Thank you, Awasha. So, it is there. Now, one of the challenges, how many of the women know that and have done it? I'm talking about who are coming in here every day. And we're talking about over 5 million Canadians without a family physician. So accessing the health services becomes a driving factor when you develop a disease, when I've developed if you are able to access the health services. Okay. What does this picture write us with? What do we look, when we look at that tree, we see we have the leaves, the canopy, and the branches, but what is fueling this are the roots. Are the roots. If that tree has no roots, it can't be there. So the roots have been supplying the trunk from childhood, now it has grown, so now the big tree has a canopy and all that. And the canopy up there are the chronic diseases. But what are the roots? Unhealthy eating habits, excess alcohol, physical inactivity, tobacco use. Those are the main roots, the major roots that are feeding this tree to be ready as we sit there. Okay. So we talked about mental health and chronic diseases. This one is bi-directional. Somebody with a chronic disease is going to enter into mental health. Someone with mental health may develop a chronic disease. So it's direction. So living a chronic disease can lead to mental health disorders as depression and anxiety, such as that. Also, what makes a person with DA, with diabetes, with hypertension, with cancer, what makes them to develop depression? What makes them to get the mental health problem?
Because they know their sickness is one way to.
That's one. So once you go and the doctor tells you, you know what, Kathy, we have discovered you have stage 4. What happens? Before you go home, you're already mentally disturbed. You're already mentally sick. But you will see that in our management of these conditions, we never have this at the back of our mind. Kathy is a health worker. Barbara, she works in where they consider this, but where I come from, you should go to see a doctor, you see a doctor, many countries do that, you see a doctor and only manage your diabetes, only your hypertension, only your cancer issue. As either a doctor and a nurse, then you go to the lab. You are people are going to find most of the systems. But we are seeing this person has a mental problem. Actually, your intervention for the chronic medical problem is not going to work unless you have tackled the mental problem. Okay? So, what causes that? The stress, the chronic pain, the lifestyle you are going to develop, that's the restrictions. You have been used to your food, to your drinks, and they said, now leave the salt. I don't know what I've tasted the food without salt. But you have lived it for 40, 50 years, eating your salt, they said, leave the salt. That when it hits hard, you can't remain the same. Okay, the sugar, huh? Or whatever sugar, leave the sugar. I said, oh my God. I live without sugar, I can't live without sugar. And that's already a problem, it's going to hit you hard. So these are the challenges that mental is going to come from when it comes to chronic diseases. If you have cancer, you say, now, 2 years I'm dying. Now, everything will change about you. But in many of our settings, we don't have the docket to manage It's a mental health problem. And it's becoming a compounding factor to poorly manage our patients with chronic diseases. If you look at that man in that state, how would he know that he has medicine to take? Remember to eat well? How can he remember that he has an appointment with the doctor tomorrow in that state? The financial burden comes with. It is expensive to manage. So all these put you down. I know minute you have a mental problem. So even mental health disorders can lead to chronic diseases. Because with your mental health, you are going to have behaviors that are hard to live with. You are going to eat poorly because you're not understanding well, and at the end of it, you are going to end up with chronic disease. So it is a bi-direction. But we are looking at chronic disease leading us to having mental issues. And what's the burden like? So according to that, the risk of developing depression among chronic diseases is that when you have respiratory diseases, you are not all that burdensome, but 30% of people living with chronic obstructive pulmonary disease can develop depression. That's 30 out of 100. Just chronic obstructive disease, which is a respiratory disease. When you look at cancer, 35 of people with cancer will develop depression. When you look at chronic pain like in arthritis mostly affects joints. So we have osteoarthritis, which comes with old age. We have rheumatoid, which is caused of autoimmune. We have gout arthritis. So all this is chronic pain. You have the joints in the morning and they are stiff. You can't even bend your leg. You can't even come out of the bed. And you're living in this life every day. You can't remain with your normal mental health. And that's what comes. 35% of them will develop that. 50%. So if you have arthritis, half of the population with arthritis are going to have a mental health issue, and may develop depression. Yes,
Doctor, why is it arthritis more in Canada than in Africa?
So, Kathy, what you're going to know is that the more a country or society is able to diagnose conditions, you will see that the burden is bigger. But when in Africa it may be there, but we don't diagnose, so we don't speak about it in most cases, and we don't see that. Secondly, the age of the population in Canada. Uganda as a country, for example, our over 50% of the population is below 18 years. So if over 50% of the population is below 18 years, you can't have arthritis. But we are going to come to Canada where the people who are aging beyond 70 years every year are more than those who are born every year. So we have an older population, and these conditions come with an advancement in age.
Is the weather contributes a lot about arthritis here in Canada?
I cannot be so sure about that. I cannot be so sure about that. But maybe the less mobility they do, being so much in the house, and we don't use our joints and all that, it may be a contributing factor to that. Yeah. Okay, so when you look at diabetes, 25% of people with diabetes are going to have depression, and people with heart diseases, 40% of them will have depression. So these are big percentages. These are high percentages. But when you speak in this language, at times there's trickle down to us. So if you say 40 because of their mental problem, social support and management, people who are depressed, they isolate themselves. Now if you have a chronic problem and you're isolated, your management is going to be a problem. Because you're going to be alone, you're going to become lonely, you have no one to help you out, and they don't want to socialize because of the depression. So it becomes a double burden on them as well. So we have biological mechanisms that also come into play, like inflammation and influence on endocrine function. We're going to have things like hypothyroidism. We're going to have like arthritis. If it's not supposed to be there, but because of a depression, it brings this into play, and we're going to have a double-edged sword in the condition we're managing. So, what does the SDG 3 tell us? Target 3.4 is talking about reducing death by chronic diseases, and says by 2030, which is about 5 years from now, we should reduce by 1/3 premature mortality from non-communicable diseases through prevention and treatment, and promote mental health and well-being. You see that target? They talk about chronic diseases, but talk about mental health and prevention and treatment. I don't know how far we have gone. Then you look at target 3.8, it says achieve universal health coverage. If you can't have universal health coverage, you may not manage chronic conditions because they are expensive to manage. So including financial inclusion, access to quality essential health care services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. So 3.4 and 3.8 SDG targets 3 go hand in hand. And we shall see whether we reach somewhere or we are still very far from where we're supposed to go with the 5 years to meet our targets. So in managing these chronic conditions, coupled with the mental health, what should we do? I want to look at a few general principles. Number one, we have got to have patient-centered care or patient-centered management. What do I mean? Every patient has unique needs. I may have diabetes, she may have diabetes, but we have different needs. We may have depression but at different levels. We may have anxiety at different levels. So every patient should be taken in a unique way as a special person. Let the care not be that the why I see Kathy, the why I see Julie, I see they all have the same condition. Am I them the same way? It doesn't work like that. They have unique needs. So we should embrace patient-centered care. We should empower patients through education and shared decision making. The patient should be involved in their management. They should be educated. If they feel they are now going off, they are getting depressed, they should speak out. They should be educated. You can't speak of something you don't know. Then we should build strong provider-patient relationships. But if you are having gaps in healthcare workers, it may be hard. So when you look at this picture, I was telling you that where we come from, most of us, you see a doctor, a nurse, and a lab, and you are done. Who is managing your mental health? Hospitals don't have therapists. They are not psychologists, they are not counselors, they are not there. So we are saying that with our patient, we need to see someone who's a nutritionist. You're talking about diet. I'm a doctor, yes. I know nutrition, yes, but I can't do everything. If I'm doing everything, instead of seeing 20 patients a day, I will see 5. So I can't do everything. Where are the nutritionists in our cycle of managing patients? Where are the nurses? Do we have radiology? Yes. Where are the behavioral specialists, the counselors, the psychotherapists? Where are they? We need them on board in our patient-centered care. So where are the dentists? So everything, we have to be a whole team to manage this patient. Who is monitoring whether your pressure is going up or down, your sugar levels are shooting or coming down? If you had mild depression, is it increasing, is it going away? So we need to regularly monitor this patient. They need to be regularly monitored. We can use technology to monitor them, such that we know how they are doing, but they need to have regular monitoring. So this becomes important for them to have regular checkups, and we can use technology to monitor them, and this can help us to timely adjust treatment plans. If we don't monitor, we can't adjust treatment plans. Whether we are changing medications, or we are increasing the doses, or we need to refer them to a therapist, we need to know them when we are regularly monitoring them. If we are not doing that, we can't achieve that.
Hi, Ricky Henry Live. Ricky Henry Live. Woohoo! Shout out to Ricky Henry Live.